coming to this training. This is about drug trends and youth development, having reasonable expectations of what our young people are going to be capable of, and we're having those conversations. We're also going to have a little bit of talk about the resources. We have Dr. Caleb Banta-Green from the University of Washington Health Services Department. He is are you the lead researcher, scientist? Lots of things. He's the drug guru, and there's plenty of articles that he has written and contributed to when we talk about drugs in the nation, and especially in Washington State. And then Johnny is just our go-to person for all drugs, and actually so he meets with actually a lot of our young people when we're talking about drugs, and so he's a great referral person. So we're gonna get out here. Start right away. We're going to have one break. It's going to be fluid whenever, in between probably sets. And then we're going to have 2 breakout sessions for questions. One's going to be right after Caleb's presentation, and the second is going to be after we talk about marijuana, just for groups to be able to really say, like, what does this mean for us, new information and all that stuff. I'm going to let you guys go for it. Thank you for being here.
So Caleb and I are supposed to speak in the microphone. It's going to be really hard for me to do, and it's going to go like this a lot. Where's my guy? Remind me, there he is. So my name is Johnny Ohta. I'm a chemical dependency counselor. I'm going to tell you just a little bit, and you're going to forget that there's some other things I hope you don't forget. So this part you can forget. I'm employed by Ryther. I work at the University District Youth Center, otherwise known as the UDYC. And I also work at the Orion Center, and I've been working with homeless youth as a chemical dependency counselor for about 16 years. I've been doing this work for about 22 years. And Caleb and I actually go back a long way, because he came out early in the years and did some research in the U District, where he used to incentivize some research, and he'd give young people incentives if they complete surveys, and I get all mad because I'm like, you're giving them money for drugs. And so I go find this guy, like, who is this guy that's giving them money for drugs? And that's how we kind of got to know each other. And then I learned a little bit more about gathering data.
What's the money for drugs?
I learned a little bit more about gathering data, then I learned a lot more about gathering data, and I call Caleb the data and death guy, because he really wants to prevent death, and he likes to do it through gathering data. And I'm the anecdotal person. I'm going to tell some stories, a lot of stories. I brought 2 props. I have no PowerPoints or anything like that. I'm going to talk a little bit about my work with homeless youth, and Caleb's going to do his thing.
Okay. Should I intro and start?
Yeah.
Okay. So, my name is Caleb, and I work with UW. I have a social work and a public health background. As I like to say, I'm not a real doctor. I can save your city, but not you. But I'm a doctor in public health. I don't know if I can save our city. I haven't done it yet. Sorry. And I started working with heroin users back in '95, so I've been doing this stuff for a little while. But I'm very much I'm a researcher, but I can't help myself to be essentially a public health advocate. But I really do good quality research to that end. What I want to talk about today is I've got data and slides, and you don't need to walk out of here with a single number in your head. This is just to sort of spark conversation, okay? And I want to talk sort of in 3 chunks. I want to talk a little bit about what are just the drug trends, what are the drugs that are out there, what are these new weird drugs, how common are they really, how important is heroin in the big picture, all that sort of stuff. Then I want to talk a little bit about opiates, meaning heroin and pain pills like Vicodin and Oxycontin. People have probably heard about the issues going on with those drugs. And then I want to share just some a few slides actually that Johnny helped collect these data from homeless youth and young adults that we just did over the summer. And just I think it gives you a good sense of what's going on in people's lives, and also what sort of things what's important to them when it comes to drugs and to their health. Before I get started, though, I just want to, in the whole realm of drugs, which is a big realm, I just wonder what sort of, what you guys would like to know, 2 or 3 hours walking out of here. Is there something that you're particularly interested in, either about a particular population or a particular neighborhood or a particular drug, anything like that? Yes, please.
I'd like to learn more about meth.
Okay.
I have a brother 6 years older than that.
Okay.
And I'd like to, because it's an issue where it's really constructed, I'd like to know how that affects them, right?
Okay, So more about methamphetamine and how it affects the brain. We can definitely get that. Anything else in particular? This is not your only chance, but.
Is this my time yet? Yeah. So here's the deal. This is going to be an interactive morning, and it is the morning. So you guys are going to go ahead and start practicing raising your hand and asking questions. So I would suggest a couple of things. One of them is you can ask some questions you already know the answer to so that other people might be engaged. You can ask some questions just because they can be smart questions, they can be dumb questions. You should just consider now starting to think about what you want to know.
Yeah?
Drugs and paranoia.
Drugs and paranoia. Okay, on a related topic, yes. Okay. Yeah, please.
I'd like to know how the drug use affects my neighborhood in Belltown.
Okay, Belltown. Okay. All right. Well, we could start with that and see how things go here. So I'm just going to dig in. So I'm going to, as I said, I'm going to put some data up here again. I'm what you call, so I am an action epidemiologist, but I'm an epidemiologist that if just squint and look for patterns. I'm not going to talk statistics. I'm not going to talk numbers. I just want you to see big picture what's going on, okay? So I'm going to show you a bunch of different data sources. And I should say, the reason I use all these data sources is because drug use is a stigmatized and illegal behavior. So it's very hard to figure out what's really going on with drug use. And so I use a bunch of different data sources. And then after I look at all the data, then I have a meeting and I have people like the DEA special agent in charge of getting bad guys sitting next to Johnny. And we all just talk about what's going on. So I really try to mix up the numbers with the real world. And this will be part of that. So these are just calls to the helpline. People who are just looking for help. This is just the last 3 years worth of data. There's not a lot of pen here, but I think what's important, these are new things, so I wouldn't worry about that, and I'll come back to that. Heroin is the big thing that people are calling about, and it's increased. Then methamphetamine is also increasing. So methamphetamine is coming back, as you'll see in these slides. Prescription pain pills, the Vicodin and OxyContin, pretty big deal, but actually coming down. Marijuana is consistent at a moderate level. Cocaine's at a lower level. And then you get things like, these are things like bath salts and spice and K2. And I actually think I could actually stop right now and just use that. That slide just kind of gives you a sense overall of what's going on. That is a pretty good ranking. That's a very good ranking of what's going on. Now I will say from the perspective of somebody whose greatest interest is in preventing death, and what we'll talk a lot about, particularly things like marijuana, is that marijuana doesn't kill you. But about 30% of users end up being dependent on it. And it is much harder, particularly as we try to evaluate Washington State's law and things, to measure subtle things like, well, I was going to go to community college, but I ended up dropping out of high school. That's a subtle thing to measure as opposed to dead people. So there are different issues with marijuana, and I think marijuana is important and significant, but in a different way. I'll just leave it at that. Okay.
So,
yeah.
you know that, so the injection use is calls just somebody calling saying IV drug use, not sure what.
Yeah, these things, let me just mention these because they're up here. These numbers are not very useful. These are brand new questions. They don't ask them consistently, but I'll just mention these topics really quickly. Obviously, injection drug use is a big deal. I will talk a lot about injection drug use. Almost all the heroin is being injected. A lot of the meth is being injected with heroin. So injection is super common, and I'll talk about that for sure. Suboxone, the reason that's up there, how many people here have heard of Suboxone? It's kind of weird. Okay, so a few people. So let me just explain this, and I'll come back to it again later. But how many people here have heard of methadone treatment for heroin? Okay, that's most people. Okay. So I'm going to go right into opiates. It's my favorite. I can't.
There you go.
I railroaded you right into opiates. People who use opiates on a regular basis, their brain changes. They start off using to feel good and get high, and eventually their body adapts to those drugs, and then they're just using not to go into withdrawal and feel terrible. So the short version of heroin is you start using to feel good, and you continue using to not feel bad. Okay, that's the basic issue. The idea is that heroin is short-acting. A lot of people using heroin are injecting every day. They're injecting 4 or 6 times a day. They never know what they're getting. They're injecting this goo. It's not good for you. It's not. You cannot live a very stable quality life if you're injecting heroin 4 to 6 times a day. It's difficult to do that. So your brain has opiate receptors in it. There's a reason our body likes opiates. Our brain is filled with opiate receptors. So what you do if somebody is addicted to heroin and they want to not be using heroin, we have other opiates we can give them that are medicines. And the two main ones are methadone and Suboxone. And they both last for about a day or a little bit longer. So the idea is you take a medicine once a day instead of injecting drugs 4 or 6 times a day. That's the basic idea. Methadone, as you might have heard, it comes out with this sort of stereotype of these big methadone clinics, and that's correct. It came out of Harlem, it came out of places with very concentrated populations of drug users where people could walk to the clinic. And we have these clinics on Capitol Hill and down on Airport Way South. And there's people there lining up at 6 or 7 in the morning to take their meds most days of the week. That's great for some people, it works well for some people, but it's a lot of burden and a lot of effort for folks. It also is a medication that the more you take, the more effect you get, and you can die if you take too much. So it can be a dangerous medicine if not used well. This medication, Suboxone, also binds the opiate receptors, but only part way. So you cannot overdose on it, you cannot get very high on it, you cannot die taking just it by itself. So it's a safer medicine. Different people do well on different medicines. The difference with Suboxone is you can go to your doctor and get a prescription for it, and go to a pharmacy and pick up a month's supply, as opposed to going to a clinic 6 days a week to take the meds. That's kind of methadone, Suboxone 101, we'll come back to it. But the issue with these is that you also find this is mostly people seeking treatment for Suboxone, which is a whole big area of my work I can talk about. People are interested in, we can talk more about opiate treatment. But that's basically what Suboxone is up there for. They started trying to track people trying to get on the Suboxone. And the issue is we have pretty good capacity for methadone. We do not have very good capacity at all for Suboxone. There's not enough medical prescribers. The systems you have to go through to get the medications are very laborious and very difficult for people to navigate. It would be difficult for me to navigate having a job and pretty good cognitive functioning and not being in withdrawal on a regular basis. But for somebody who has none of those assets, it's going to be really challenging. So as a side note, we're actually doing a lot of work in the county right now to kind of fix that issue. Is that good enough? What do you want to say about it?
Yeah,
I just want to, a few people raise their hand knowing what Suboxone is, and a few people raise their hand knowing a little bit about methadone. And I would hope a couple of things, but mainly that you walk away from this training having some more understanding about this, so that in the future, when someone says buprenorphine, which is Suboxone with naloxone, if they say Suboxone, that you know what it is and that you understand what it's used for. And that if people talk about methadone, that you don't think it's methamphetamine, and that you understand that these are medication-assisted therapy. And then we're going to talk about that a little bit more today, because Caleb and I have this thing where we agree and disagree about some things, and we're going to talk about that a little bit. But we're also going to talk about what we do as service providers to help people address addiction, and this is a really big part. The methadone, Suboxone, heroin addiction, opiate use, overdose prevention, what it is, what we're doing about it, what we can do about it, working with homeless youth. So I've gone to, I'm not scolding anybody, but I've been to a lot of trainings where I've talked about these things, and I come back and people still are like, I don't know what that is. So I challenge you to know what it is when we're done. Thank you.
Uh-oh. The good news is there's a Cliff Notes version on the website that I'll give you so you can pass Johnny's quiz. I got a one-page summary, so I'll take care of you. Yeah?
A quick question. There's not any data for 2012 for Suboxone. Is it new?
Suboxone's been around for, I guess, about 10 years now. So the answer is no. This is just a data issue. And the helpline's been around longer than this, but it switched. It's now at the crisis clinic. So that's just why the data are not there. So methadone's been around for more than 30 years. Suboxone's been around for probably a little more than 10, I think.
Yeah.
So it's newer.
Yeah,
Yeah. Okay. Yeah, good question. So I'm going to not worry about this. This is basically police evidence, which I'm not going to bore you with because it says the same thing with lots of funny looking graphs. But those data are basically what are the police getting off the street. This is something totally different. This is, I'm starting off with kind of measures of use, okay? And then I'm going to go into measures of problems that happen related to drugs. This is, to me, very interesting around marijuana. I try to focus on opiates because 3/4 of fatal overdoses are due to opiates, so that's what I work on. But marijuana is interesting. It is important. If we were having real conversations about why people use drugs and alcohol and medications in our society, I think that'd be fascinating. And I think marijuana would be a great gateway to that conversation. So I do think marijuana is very important and also has important negative impacts on some folks. These data are basically just showing from left to right 6 years worth of data. This is high school seniors in King County. And so what you see on the left side is I'll start over here on no use. So we went from having 18% of people using to having 26%. So we had a big increase in just past month any use of marijuana over this time frame. But then what I think is actually the most interesting and important is starting back here in 2008 was the increase in 10 or more days of use. That's a big deal. Any of this is a meaningful deal for a high school or for an adolescent brain. Any use is a big deal, but using into the week is an even bigger deal. And that's where we saw a pretty meaningful big jump to the point where you have 1 in 10 high school seniors saying they're using during the week. There's a lot of high school seniors out there. That's a lot of use. What's also important to see is that the law didn't pass until 2012 and stores didn't start opening until 2014. So the point is people want to know what's the impact of the law. The law is the last thing to change, right? You can sense the attitudes, the practices in Seattle that have been shifting for 10, 15 years, and that's what you see here. The law is just the last thing that sort of documents firmly what's happened. So we do have an increase in marijuana use in the United States. We do have an increase in marijuana use in Washington State and in King County, and we have more people using more often. And we'll talk more about that. So this is just about treatment admissions, and I just want to focus on big picture stuff here. So this is publicly funded treatment in King County. You can get a sense of numbers here. So this blue line is alcohol. It's not that we think the demand for treatment for alcohol is changing. We think that priorities and treatment access are changing. But what's important to see here is that this is alcohol going up and down, and this red line is heroin-related admissions, to the point that you have basically the same number of people, same number of treatment admissions for heroin as you do for alcohol in our county. And if you look at people in their 20s, you have more people coming into treatment for heroin than you do for alcohol. So that's important to know. Marijuana is kind of persisting, and in fact, these numbers are going down over the last few years. A lot of people coming into treatment are forced to go into treatment by criminal justice situation. So we think that's a big chunk of what's going on with marijuana admissions. But we certainly know it isn't like it disappeared to zero, for sure. We're definitely still seeing it. This orange line is cocaine, and we've definitely seen a bit of a drought in cocaine the last few years. There's still plenty of cocaine out there, but there's less than there was. These are these prescription opiates here, this blue line, and what you basically see, we saw a huge increase throughout the 2000s, and things leveling off and even decreasing a little bit in the last couple of years. And then where's methamphetamine? So here's methamphetamine just trucking along throughout the 2000s, dipping a little bit and definitely coming back up. And that really parallels also, I didn't show you all the helpline data, but that same type of situation is what's going on there. Anything else?
Well, yeah, I mean, there's some service providers here, and I guess maybe if you guys now are, you know, when we have other times, thinking a little bit about this, but obviously working with homeless youth right now, we are seeing we're seeing this consistency with more of an uptick for methamphetamine use, and the question about paranoia is tied into methamphetamine use. And so there's some things around that that are very important for us working with homeless youth in King County, how we're different approaches and things like that, and really what it is, what it looks like, and then maybe back to what Nicole was talking about a little bit, what are reasonable expectations for our young people using methamphetamine. So that's an area that also we're going to talk about, but it's important to understand meth is very consistent in our community right now, and it's kind of, in some ways, I don't know about the service providers, I'm pointing to this table, kind of drives us crazy, because methamphetamine is crazy making. It's very hard to treat, it's very hard to work with people, but we've had a lot of successes recently in working with some young people who are using methamphetamine, so that's also an important part of this, is to understand. Sometimes when people are using meth and they're very, very paranoid and they're very freaked out and they're very scattered and they're very psychotic, it feels like we can do nothing. And then it turns out after a while, when we're patient and consistent and sometimes persistent, that some very positive things can happen. So I think that's just a really important point, that we can get lost in some of the other drugs that we're going to talk about.
And I'll just mention, really, just to follow up on that and then come to your question or comment, is, and I'm not an expert on methamphetamine, but in talking to my colleagues who do research in this area, one of the things we find with methamphetamine is there are some drugs where, you know, going to a drug education class and learning about the drug and learning about cognitive behavioral therapy and doing all these cognitive thinking things work pretty well. Not so much for methamphetamine. Methamphetamine, you're really talking about essentially really starting with kind of getting people socialized again, and just sort of getting them in a normal way of relating to people for a while, like for months, before they're really able to regain sort of their cognitive functioning and start working on some of the other things in their life that they might need to put together. So it's going to look different than some other drugs, and the point is that that's real and that's biological.
Yeah. You had a question?
Well, I was talking to some kids Tuesday and drop in that they said they had a horrible day because they dropped acid the night before, and I didn't see that in their, where does that fall, the LSD?
Yeah, I mean, there's LSD.
And how high is prevalent is that in the numbers?
It's barely in the numbers. There definitely is LSD out there. There's definitely shrooms out there. There's definitely things. There is actual ecstasy and lots of bogus ecstasy out there. Well, I didn't show you all those, but those things are definitely out there. People are still using those. The thing I would say that is really important about the psychedelics and or the hallucinogenic psychedelic stimulants, things like MDMA and LSD, those things are still out there, but what's happening now is that you're way more likely to get who knows what. 10, 15 years ago, if you took LSD, it was probably LSD. If you took MDMA, it was probably MDMA. The chance of it being that drug now is unlikely. And that's a lot of synthetic drugs. I mean, hundreds of new drugs are coming out every year, mostly out of China. I have a group in Europe's been tracking. There's like 500 new drugs in the last 5 years. So the point that I would say is we do see those drugs. What I often talk about, people always want to know about a specific drug. The point is, you don't know what a drug is that you're taking. The chance of that is extremely small. You don't know how strong it is, and you don't know how it's going to affect you. So those things are those are universal things. So they may think they took LSD, maybe they did take LSD, but who knows what they actually took. And that's definitely a changing dynamic than it was 15 years ago.
So on the drug trends topic, I mean, recently I've heard a few young people say that they were taking acid, that they just took acid. And then also what Kit was talking about, and part of the drug trends group where we are actually lucky enough sometimes that there's seizures where they take the drugs and test them in the crime lab and find out a lot of information. And a lot of that information is that it's not the drug that it was being sold as, and so that's a really important thing. And our young people, our homeless kids, they're the worst targets for selling stuff to and saying it's one thing and it's not another. They're not really like connoisseurs of drugs. They're like, oh, I took acid, I got high, it was great, it was bad, it's whatever. They have no idea. And so, but the reality is that they took a drug, something happened, and they came and told you. And the psychedelic part of all this stuff is kind of a small part of a bigger picture, but it's definitely a part of what we see definitely here and working with homeless youth.
And just from a data perspective, so if you look at something like how much the police are getting off the street for heroin, they're getting like 400 cases a year in King County. You come over here, and here was MDMA at 40 cases back in 2010. Very hard to actually find MDMA. You're finding other synthetic stuff. Don't worry about what a phenethylamine is. But MDMA is one of them. But the point is, these are going away. There's other weird stuff coming in. Cannabimemetics means fake marijuana. It's spice and K2, very small numbers, like 10. I mean, it's out there, but there's not a lot of it. And these cathinones are things that are like fake MDMA, basically. So they're out there, but they're very small numbers. And I actually don't even see lysergic acid. I don't even see LSD on there. I know it's out there occasionally, along with shrooms. Wrong mic, my bad. Yeah?
So on both on the first graph you showed about increase in use, and then the increase, or the last graph you showed about people entering treatment, there's a correlation between opiate pills and heroin use, and like what I noticed is right where the decline in opiate pills happens is like a spike.
Are you an epidemiologist?
No, but
You should be.
But there was like, if we all remember the surge of pills, and I'm just wondering if you think there's a correlation between the pills and the...
I'm the world's first researcher to document that. Yes. In King County in 2009, we asked heroin users, before you began using heroin, were you hooked on prescription opiates? And it was 40% back then. It's like 65% among those under the age of 30. And that number's continued to increase. So there's a very, very high correlation. And the issue is, we reined in opiate prescribing in 2009, 2010, without thinking about that just getting rid of prescription opiates does not get rid of opiate addiction. We did not supplant that and make sure that doctors were trained in a recognized addiction and actually treat addiction in their medical practice. So they're completely correlated because it's the same thing. I don't know if I have up here or not, I don't think I do. But if you see a molecule of OxyContin and a molecule of morphine, unless you're a chemist, you're not gonna be able to see the difference. And your brain can't see the difference either. They're the same drug.
Do you guys, where do you get your news from? Do you read the Huffington Post? Do you read the New York Times? Somebody raise your, do you read the Huffington Post? Any of you? Where do you get your news? NPR, where else? Facebook. Oh, that's bad, Nick. Where else?
He's being honest, he's being honest.
Where?
TV news.
TV news. Anybody else?
Online.
Online. So this, what Nick's just talking about and what Caleb was just alluding to, is a national epidemic that's pretty much on every news media you could find. So what we're talking about Suboxone, methadone, heroin overdose death, why is this an epidemic? Why is this going on? Is this happening in our community here in Seattle? Yes. And it is on everywhere, these national stories about the increase of young people switching from prescription opiate drugs to heroin. So part of it is like, this is happening and people are dying nationally, and the other part of it is this is happening and it's happening here in our community and it's happening with our young people. And then it's really, this is a big focus of ours, is really figuring out how to treat it and how to prevent death. So, you know, NPR obviously has had a lot of stories about this recently, and you know, if you read the Seattle Times, it's okay, but there's really, you're not going to get a lot out of it. If you read The Stranger, there's going to be some things. But recently, this has been over the last couple of years now that this national epidemic has really taken a lot of attention. It's really just because people are dying. So as you know, we walk through trying to figure out how to do this, knowing that it's something nationally and something that is happening, you know, with the kids that come to New Horizons.
Okay. And it took a long time, but actually for the first time, President Obama started talking about it this week when he was visiting West Virginia. So that was you know, a little late, but there you go. That's definitely not the button I was supposed to hit. What did I hit?
Question for Johnny really quick, is that all right?
Yeah, please.
What I also noticed is the increase in use with methamphetamine is not really, it hasn't changed the increase in entering into treatment. Like meth users aren't seeking to access treatment as quickly as their increase in use is happening. I just wanted to know what that is, because we see it a lot out here in service. It's just really hard to get people using that.
And I'll, yeah, actually, you follow up on that, and then I'll talk about the data.
I can follow up on that. Now I almost forgot the mic. So the deal is, and Nick kind of knows this, but for a lot of us, is that it's really hard to get methamphetamine users to follow through with everything you need to do to go to treatment. And it's a little bit easy. I always say I'll take an alcoholic or a heroin addict any day in trying to help them sort of walk down the path of going to treatment, going to detox, getting on Suboxone, getting on methadone. Because there's a certain point when those two drugs have a very specific withdrawal, and methamphetamine has a withdrawal symptom that has this very long post-acute withdrawal and this relapse cycle that's very challenging to get them to show up. So just for us, and then just out in the community too, families that call us and say, well, my kid's on meth, what should I do? And first of all, we just kind of roll our eyes. They can't see me because I'm on the phone. And then try to go down this much longer path of really getting them to show up for some things, to show up in a reasonably stable state where they can get an assessment, sit still, and end up in some type of treatment. And so that's also why treatment centers also aren't really like all happy to get a bunch of meth. We're like, oh, this is great. We have like 10 people that are trying to stop using meth, and the needs they have are greater. Even though alcohol and heroin have this very specific need for medical treating the withdrawal, the psychological issues with methamphetamine make it more challenging to go to treatment.
And just the little data foible here is this is the primary drug that people mention at treatment, and most people use multiple drugs. That's just the data point there. So on that point, just to show you really quickly, I'm going to go through a few things about who's showing up in treatment. This is just looking last year at 2014 data, and you can see that it's a majority male. Certainly, for alcohol, it's about a third. You see more like 40% are female for heroin. The biggest group is prescription opiates, and then methamphetamine as well. So these are sort of the three drugs where you see more women presenting for heroin, meth, and the prescription opiates. In terms of the age distribution, really different across drugs, right? So alcohol is really old people. Just kidding. But 45 and up. You know, it's people 30 in their 30s and their 40s and older. Cocaine, even older. You know, we have kind of this cohort effect where a lot of people using cocaine are just a lot older, and younger people are not using cocaine, they're using meth, which we'll talk about. Heroin, this is new, that you've got 40% of people under the age of 30 coming into treatment. That's a new thing, and to your point, the fact that this is identical with prescription opiates is not chance, right? Those are largely the same people. Methamphetamine, a lot of really young people, a lot, and also this is interesting to me that we're getting some under 18. And then marijuana is where you really see the younger folks coming into treatment. So just give you a little sense by age of what's going on. Also, just to remind you, this is just publicly funded treatment. This is not any of the privately funded treatment at all. And it's very little of the Suboxone treatment, because 90% of that is privately funded as well. So this is just a slice of what's going on. Looking at it by race, ethnicity, I know we think Seattle's all white. It is not all white. But you also see this is going to be lower income, so it's going to be a smaller proportion Caucasian, but you do see overrepresentation. And that's largely because of the criminal justice system referrals. That's largely what drives a lot of that. So you see alcohol, about half Caucasian, maybe 20% African American. You can see Hispanic, Asian, and so on. Cocaine still is largely African American in the Seattle area. Heroin is largely Caucasian, same for prescription opiates, but not entirely, right? The one thing is you got people who are reporting multiple races, so it's hard to know how they might predominantly identify, but just give you a sense of what's going on. Methamphetamine, primarily Caucasian, but it was much more white 10 years ago, much more white. It was definitely spreading out geographically and demographically in terms of methamphetamine. And then you see marijuana, and you can see some slight racial disproportionality. Perhaps that has something to do with the criminal justice system. I'm just saying. So what we have here is route of administration. So cocaine, people coming into treatment mostly smoked. Heroin, mostly inject, not all, some smoking as well. Prescription opiates is mostly oral. You don't get a ton of injection of the prescription opiates. You get some, but not a lot. Methamphetamine, mostly injection, but mostly smoking, but definitely a good chunk who are injecting methamphetamine. And in marijuana, what's actually important, and we see this a lot, the vast majority of marijuana is still smoked. No matter how much edibles are sold out there, it's still mostly smoked. And then hitting on this here really quickly, this is about some of the other drugs, in part to your point. With alcohol, marijuana is the most common secondary drug. For cocaine, alcohol is the second most common drug. Some people are maybe aware that a lot of people use crack and alcohol together because you get sort of this unique effect when you use those compounds together. So there's a relationship between cocaine and alcohol. Heroin's a little bit of everything, but what is new is that it used to be cocaine was the most common secondary drug with heroin, and now it's methamphetamine. So that's new. For the prescription opiates, you get a bunch of people saying heroin's their secondary drug, so that's kind of interesting to come in and say, well, pills are my main thing. Oh, and I use some heroin too, right? So this is kind of artificial. Methamphetamine, you also see a bunch of heroin, you see a bunch of alcohol, and you see a bunch of marijuana. A lot of variety of things for people using methamphetamine. And in marijuana, most people, mostly because they're younger, using alcohol with a few other drugs as well. So it's really about polydrug use, and there are some specific patterns as well. Just to mention, in terms of opiate treatment programs, this is basically methadone maintenance in King County, and the point is the numbers have been increasing a little bit. I would argue we need at least 2 to 3 times as much treatment as we currently have. This is getting into a little bit about drug-caused deaths. I do a lot of work with the medical examiner. It is sort of the ultimate thing that we're trying to prevent, and the nice thing when it comes to opiates is we have really good tools, just not a lot of people have them or even know about them. So you can see the overall death rate in King County. The number has gone up tremendously, almost doubled, and the rate has gone up by more than 50%. So in King County. So we're close to a person a day dying in our county from a drug overdose. You probably don't hear about that a lot. You probably hear about people getting hit by trains, but there's a lot more people dying of drug overdoses in our county. This is my favorite spaghetti plot. I apologize in advance. This blue line, just follow follow the little light. The blue line's heroin. We had a lot of heroin-related deaths back in the day. Came down, leveled off. Now, by far and away, our most common drug that we're seeing in deaths. The red line is prescription opiates. Went up, is coming down, has not disappeared. Alcohol just kind of persists in here, this green line. Cocaine's all over the place, maybe a little bit of rebound. I do want to mention really important benzodiazepines, this orange line. Benzodiazepines, so that's Valium and Xanax mostly, right? And those are 99% of the time with other drugs, usually with alcohol or with heroin or maybe the prescription opiates. They add together and create a stronger effect. So those are used very commonly together, and it increases the risk for overdose. Yeah?
Just a quick question with the lines increasing the last few years, because it hasn't Seattle's population increased.
Yeah.
Does that have anything to do with
So that's why this one here has numbers and rates. So the red line is a rate, this is population adjusted. So yes, our population has increased, which is why there's almost doubling in the number of overdoses is only a 50% increase in the rate. Does that make sense?
Yeah.
Okay. All right.
Caleb, you may talk about it now or later, but the combination of drugs that cause death and the increased probability of dying, and depressant drugs kill people more than other drugs, so you obviously are going to hit that now or later.
I'm going to hit it now, Johnny. Okay. So methamphetamine will be my entry point. Thank you so much, Johnny. So methamphetamine, we were trucking along at about 20 methamphetamine-involved deaths, drug-caused deaths per year. And I should be really clear, these are drug-caused deaths. And what I heard, it was very surprising to me that these numbers were so relatively low when you would see 5 times as many cocaine deaths. We weren't seeing 5 times as many cocaine users. So what you generally heard is methamphetamine isn't as deadly as cocaine. It doesn't give you a heart attack and kill you. It does other stuff. Mostly what I heard, and I don't mean to be superficial in this, is it makes you do dumb stuff that kills you. The drug itself isn't what kills you. It's the dumb stuff that meth makes you do that kills you. So then it's called a electrical hedge trimmer accident in the middle of the night, right? By the way, they were on a lot of methamphetamine because they decided it was a good time to trim their hedges, right? So what the issue here is that half of this huge increase in methamphetamine-involved deaths from 20 a year to 70, at least half of that is with heroin. And that's what's new in the last couple of years is this combination with heroin. So methamphetamine is not as deadly as cocaine as far as we know, but when you start combining it with opiates, it is. And the issue is, and I got a medical student working with a medical examiner right now on this topic, basically what happens is opiates slow down your breathing, methamphetamine speeds up your heart rate. So your heart needs more oxygen when it goes faster, but your breathing's slowing down. So you just have these two opposing forces working at the same time, which can kill you.
I have a question.
Yeah?
It looks like something spiked, or the opiate spiked in like 08, 09. Have you seen like a correlation with current events, like that's obviously the recession and housing drop that makes other drugs spike or whatnot with deaths?
So these numbers do bounce around because they're thankfully relatively small, but prescription opiates, that is perfectly correlated with prescribing, perfectly. Those numbers follow the prescribing trends for opiates perfectly. And it's not that everybody who was taking the drugs prescribed to them was using them and dying from them. That's probably about half of the people with prescription opiates. But it was also then just a diversion source, whether people were selling them or stealing them, there were just that many more opiates out there. I think this number is about right. A couple of years ago, we had about 30 million doses of Vicodin sold in 1 year in Washington State. That's like, that's about 5 pills per person. There's just a lot of meds out there. And that's just one of the opiates. So there's tons of opiates out there. And that's, what's that?
Can I ask you a question
Yeah.
about that too? With that huge spike in those opiates and doctors prescribing, was it just a huge influx of people that needed that drug, or was there a push on by the pharmaceuticals to get the drug out there? Or?
I'll try to give you the short version of this story because it literally is a couple of books. But basically in the mid-90s, pharma was pushing and the health boards for states basically were getting told that chronic pain is a public health crisis. We need to treat this crisis, and long-term opiate use is the solution. And so we saw opiate prescribing increase dramatically throughout the late 90s and through the 2000s. And now that pendulum has swung the other way, actually led by Washington State, led by Dr. Franklin, who's the head of labor and industry, because he was seeing people come in with back pain, getting Vicodin, and dying of an overdose 6 months later. So he's led the nation. It's actually, Washington State has led the nation in terms of reining in opiate prescribing. The challenge is, you know, it's relatively easy to control doctors and restrain them, relatively. Not that easy. But getting them to do something new like understand addiction and actually want to treat it in their offices is way harder. Way harder. And they're simply not doing it. It's a difficult job. They need more supports to do it. They need reimbursement to do it, all that. But basically, they don't know how to deal with addiction. They don't understand addiction. They don't know how to deal with addiction. So that's how we got here.
So I had
Yeah.
a question on that graph. You have a list of drugs and then it says heroin probable.
Yeah.
Is that a fuzzier to figure out people that heroin? That's that.
Let's just call it heroin. That's just me being a good researcher. I can give you the 5-minute footnote on it, but basically, heroin metabolizes very quickly and it's hard to prove it. Our medical examiner actually since 2005 has had a new approach to documenting heroin. So that's just me being extraordinarily conservative. But yes, they're heroin deaths. And I'll just, as an example, I just pulled the Seattle opiate deaths, and basically 3 out of the 100 probable heroin, I'm going to say, are probable heroin, and the other 97 are like definitively heroin. So it's a very minor thing. It's just me being a cautious researcher. There's a question behind and in front.
How are the numbers affected by all the new influx of people that are here? Because you mentioned that the number of deaths had increased to like 1 person every day in Kane County. And so how is that percentage-wise in accordance to how it might have been before because there was a lower population in Seattle?
Okay, so that's just this question, I think, about how many people are dying in the population. So the point is, yes, our population has been increasing, and the point is we've had almost a doubling in the number of deaths, but it's a 50% increase in the rate of deaths per 100,000 people. So we have a real increase in the number and a real increase in the rate. Yeah.
The graph on the next slide, is it possible to make that for drug-involved deaths in addition to drug-caused deaths?
The question was about, can you make this about drug-involved deaths and drug-caused deaths? You can, it just gets really tricky. So the point, though, to your point, this is extremely conservative. This is a gross underestimate of the amount of involvement of drugs in deaths. And this is just deaths that are due to an acute medical crisis. This isn't about long-term consequences. This isn't HIV or hepatitis C or anything else. This is just the drug killed you that day.
So I'm curious how it would change the rankings.
How it would what?
Would it change the rankings in addition to the overall numbers?
I don't think it would change the rankings very much. I mean, I think if you were looking at all-cause mortality, which is things that may kill you slowly, alcohol would bump up when you start seeing cirrhosis. So you'd see an increase in alcohol. That's the main difference I think you'd see. Okay, I'm going to keep plugging away. So the point is, I won't belabor this, that the deaths are increasing across King County. This is by age. This is heroin-involved deaths. This group here is the under 30 group. This is 31 to 40, people in their 40s and 50s. Most of the increases you can see went from 7 to 42 deaths over the 6-year period for people under the age of 30. So we've had an increase that's largely driven, but not entirely, by people under the age of 30. We don't usually see people that young die. We actually, all of the existing literature on heroin says, oh, you die when you're in your 40s, when you're older, and your lungs don't work as well. That's incorrect. I'm not going to belabor this, but the point here is this is where the deaths were. They were mostly in the Seattle area 15 years ago, and now you can see a much wider distribution. As a side note, so all deaths are these dots all put together. The purple dots are those under the age of 30. So we basically were seeing almost, if you're looking over here in the Kirkland area, about the only people dying of heroin overdoses when there were none are people in their 20s, just as an example. The point here is simply whether it's heroin or prescription opiates are both consistently about 3/4 of overdose deaths involve an opiate. And what we're going to get to is that what's good about that is that we have an antidote that anybody can get, and we have very effective medication-assisted treatments that people can be on. So this is, if you could really tackle this substantially, you could have a huge impact on mortality. Yeah?
So I'm wondering, with the trend of meth and heroin being injected together, if someone is going to treatment for both, can they take methadone, and can that be successful if they're still putting meth on that addiction part?
So the question is about if a person is using meth and heroin together, and they take methadone or buprenorphine, can they be successful in treatment? Is that the question?
Yeah.
So let me answer that question. The answer is it's much harder. So my dissertation now, 10 years ago, basically was the first time that we knew that a person coming into treatment uses heroin, has whatever chance they have of getting to a year's worth of treatment. That's cut in half if you use cocaine. Your chance of staying in treatment a year drops in half if you use cocaine. We then found the exact same thing for methamphetamine because the medication is doing nothing for those stimulants. And we don't have great medications. We don't have medications for those stimulants. People are always curious about, oh, well, couldn't you just give them Adderall? That doesn't work. I mean, it doesn't work well, at least. So we don't have good medications for those stimulants. It really is a substantial problem. I would also say, though, looking at this from another perspective, and this is a change that's happening, and I didn't mention I have an overdose prevention study in the Harvard Review ER, and what we find is that in the old days, it basically were, if you were in methadone and you're in Suboxone, you're going to get your analysis, and if you're using any drugs, you're kicked off the program. That's changing. The reason it's changing is that you're much more likely to die if you're not in treatment. So it depends whether your bottom line is a person being, quote, clean or abstinent, or whether your bottom line is them being alive. Because if your bottom line is them being alive, you want to keep them in treatment. It's not about them being perfect. It's not about all of that. It's about keeping them alive. So what we found in a Harvard Review ER is active heroin users who were showing up in the ER, 30% had an overdose in the last 3 months. That is a massive number. Those same heroin users, the other group who were also in methadone and continue to use heroin, 10% had an overdose in the last 3 months. There's a big decrease in overdose risk. The reason is, to dork out on opiates, is that if you have a high tolerance of opiates, you're less likely to overdose. It's having a drop in your tolerance and using, which is generally what kills you when it comes to opiates. So that's kind of a plug for people who are on these medications. You really want to do your best to keep them on their medications. And sure, you want to work with that person to get their coke and meth under control as well, but you probably don't want to kick them out of treatment because their chance of dying is higher. But I want to know what Johnny thinks about sort of stimulants in opiate treatment.
Caleb just said a lot of things that we probably don't have time to talk about all of that. But number one, your question is very specifically, you're talking about people being on methadone treatment, methadone maintenance treatment, which would be that you're using heroin and methamphetamine and you go to treatment, which is not going to be an outpatient setting. It's not going to be going to inpatient. It will be going to a methadone clinic it's medication-assisted treatment where they give you methadone every day, and they provide a little bit of structure around it, which is you have to go there every day. And then trying to address the fact that you have a stimulant addiction combined with that. One of the things about combining depressants and stimulants is it works really well. You get really high, and then you tend to really like that high. And then you go and get on methadone, and you do that because you want to change some things and you want to change your life and you're tired of shooting heroin and all these other reasons, or maybe, me and Nick went over and was like, man, do you want to do something about it, whatever. And then you go get on methadone, but then you go and shoot meth or smoke crack, and it actually has a pretty similar effect as when you're using heroin and stimulants. So you're kind of like, this is cool, we're good. And you're kind of happy, as a matter of fact, as an addicted person, that this is working well. We are providing an opiate for you to substitute for heroin, and you're going to acquire this other stimulant. So, and then what Caleb's talking about a little bit is how the rules have changed. So the rules no one's rolled out and said to us, like, the rules are different at methadone clinics now. No one's said that, but 10 years ago, if you had dirty UAs for other drugs, you kind of got in trouble and you had to go talk to your counselor, and then they held your dose, and then they did all this stuff, and then they kicked you off. And now, what we're seeing, and I don't know if Caleb really knows the answer to this or not, is that they really understand that people die less, and that these rules have changed because of that. I'm not really sure. No one's really made that statement from methadone treatment, but what has happened is, and we have many young people on methadone that we work with, what has happened is that they don't really put that much pressure on you for having dirty urinalysis tests for stimulants. They do have you go to groups and do other things, but they don't kick you off. The only thing they really kick you off for now is benzodiazepines, because if you combine those two, it does kill you at a much higher rate.
Yep.
So just thinking about the conversation of being in treatment, which means being on medication-assisted treatment, using those other drugs, and then really working with people on trying to what we really do is like, man, can we work on you reducing your use of these stimulant drugs so that you can focus on stabilizing on methadone and then maybe go get an internship at New Horizons or something like that?
So I'll come at the question, but let me just comment on that really quickly. And I think the big issue with methadone maintenance is a lot of people are just working the system. Some people are really trying to get clean. That is to not use heroin. Some people are trying to get a break. And you can see some people do really, really badly on methadone. And that can be very frustrating, and it can put you off on methadone. And some people don't do well on it. And different clinics are better or worse at doing counseling and doing treatment and taking care of their patients. There's a lot of variability out there. What we know, and so this is this tension that I have as a person who is a social worker and a public health guy, is I want to work with that person. I want to talk with them. I want to work them through their addiction and what it means and get them to really rethink their life and work and function in a new way. I want that to happen. The public health side of me is like, I want them alive. And the point is, that's harm reduction. Methadone is harm reduction. It's reducing harm. It's not sort of creating perfection, right? You're trying to make things better. But I also think it's important that when we're thinking about addiction, a lot of times we're saying, well, it only works half the time, or it only works 2/3 of the time. Well, so do antidepressants, right? It isn't like counseling and antidepressants are magical cures for mental health issues. They're not. So we need to just make sure we're not having a different standard for addiction as we are with other medical conditions. So that's just kind of what I would have put out there. But I think it's important to know that, methadone can work really well for people, and it can add some good structure for some people, and for other people it does not. And the nice thing is we have buprenorphine. There's also some people who feel normal or more better on buprenorphine than in methadone. We actually have a choice. For a long time, we really didn't even have a choice. So we at least have that option out there. Big question.
When I hear you referring to methadone maintenance, do people that go into methadone treatment, I mean, is it possible that they come out and don't use after going through the treatment, or is it pretty much when you need that support?
Yeah, so it's a great question. So we often do use the word maintenance. And some people are on methadone for years and years and years and years and years. And some people are on for a few months. And so there's just all different pathways for people. The way I look at it, whether it's buprenorphine or methadone, when buprenorphine was introduced, people were really excited. Like, oh good, this is going to be a detox med. We're going to get people off of heroin in 3 to 6 months. And much to their consternation, every new study says the longer the better. The longer the better. And you'll see in a summary I have, which you're welcome to look at later, the point is, I would make the judgment about how long a person is to be on that medication is as long as their functioning is being improved. If their functioning is not being improved and it maybe is increasing harm, then they probably shouldn't be on the medication. But rather than this artificial timeline of, oh, you get 3 months or you get 20 years, it really should be tied to how are they doing in their medically, socially, work, school, all of those things. So does that make sense? Yeah, so, and the point is there isn't one trajectory that works for everybody. It's all over the place.
So anywhere you go, if you go talk to people or you go talk to your friends or you go have dinner with them tonight and you talk about methadone, some of them won't know what it is, and then some of them will be like, that's that stuff you use to get off heroin, right? Am I right about that? Mm-hmm. That's the general public. Either you don't know it all and you're just oblivious, or you think that's the stuff they give you to get off heroin. And so then you go down this line, this explanation about methadone maintenance. And so you go to methadone clinic and they take you in and they find out that you're an opiate addict, and pretty quickly they assign you to methadone maintenance, which is we're just going to chill with you. You're going to come every day. We're going to up your dose until you stop complaining, and then we're going to keep you on methadone maintenance. And so really. The majority of people, and there's data on this, stay on methadone for a pretty long time. Back in the day when people were kicked off for having dirty ways and other things, you had more people getting kicked off of methadone maintenance programs and choosing alternative paths. Right now, you're having more people who don't get kicked off and stay on methadone and really use it as a maintenance drug. Caleb's friend, Ron Jackson, my friend too, we argue a lot. He likes to talk about the methadone success stories, which if you go to a methadone clinic, and I go to them often, people just don't look very healthy. They don't look well. I know school teachers, I know people that drive school buses, I know people that are UPS drivers, I know people that are working in all kinds of different areas in Seattle who are on methadone. And they look pretty clean. They look fine. You wouldn't know unless they sat on the couch kind of late in the day and they fell asleep, or if you looked at their eyes and they're very constricted. So they're very high functioning people operating in the world on methadone maintenance for many years. The thing is that we work with homeless people, so the combination of homelessness, being on methadone, living on the street, also having other addiction issues really combines a lot of health problems, and so that's kind of a big issue. But just the clarity about maintenance, when you sign up, they will keep you on, that's kind of a conspiracy theory thing, but the clinic will really want you to stay on methadone as long as possible.
And this is super interesting and super important, and we don't have great data on it, but that's a big deal, right? And we've talked a lot about this, and other people, you got young adults, they're like, yeah, I used heroin for a year, I've been on Suboxone for a year, I'm ready to get off, I'm 20 and live my life. And the medical providers, please stay honest. Like, your chances of an overdose are double if you're not on this medication. And at the other time, you've got this young adult who's like, I don't want to be an addict, I don't want to have this as my identity. So I don't have an answer for that. It is a real tension. I think that sending a lot of young adults down to a methadone clinic in Soto with a bunch of people in their 40s and 50s, that's not necessarily the best idea for a lot of people. And we're actually in the middle of, right now, trying to sort of radicalize and rethink how we do this and actually get care and buprenorphine out to people in the community where they are. We've been meeting with the mayor's office on this for a couple of weeks. So we're trying to shake that up. We're trying to rethink how we do this. So methadone is an option, and it is good for some people, and it is not a good option for other people. Maybe that's what we say. John, you're not going to do this all day. You're going to watch Johnny.
This is tough. I'm going to answer your question, and now is my time to just really bring in the part, and I hope that you guys are okay with this, but this is the thing where we have the back and forth. And I'll just admit, I should have admitted my bias earlier, but I'll admit it now. I'm in recovery, and I also have been on methadone in 2 different methadone programs, so I'm highly biased and get all emotional when I talk to my friends about this. But the main deal is, like, I have many parents talk to me all the time, and if you called me tomorrow and said, and this just happened to me last week, and it happened to me 4 weeks ago, a parent calls me, my daughter's on heroin, what should I do? And if they call Caleb, they're going to get a different response than me, because I will tell them, first and foremost, try your best to not have them get on Suboxone or methadone first. Now, this has happened 4 times in the last 3 months with parents calling me and walking through this process. 3 of those young people ended up going to treatment. It was a long, difficult path for them to get to treatment, but they went. The main deal is this. You come to me and you say, my so-and-so, my aunt, my uncle, Mary is on heroin. We just found out, the board's intervening, what should we do? And so we're like, well, let's go talk to Mary. And then I'm like, Mary's an adult, so I might be like, Mary, what do you want to do? But really, I'm going to tell Mary after I ask her what she wants to do. I think you should consider going to treatment, and if you go to a medical provider, they're going to suggest that you get on Suboxone. I'm working with quite a few people, and very closely with 2 people getting off of Suboxone right now. So, and it's ugly. It does not look good, and it's very difficult, and withdrawal is very hard. Caleb doesn't want people to die. And the really big deal about this is, if you take Suboxone every day, you cannot die of opiate overdose, period. You will not die. So he's saying, you're 23, you get on this medication, you stabilize, you're not going to die of an opiate overdose. It's a good argument. So we have this little back and forth. It's a good argument. And these guys, him and Ron Jackson, all these guys are a little smarter than me, and I'm a little more emotional than them about this stuff, so that's my little piece on that. But as we go down this path, we're trying to really give people a lot of options and educate them.
And we're going to end with a whole set of slides that were making me emotional yesterday when I was looking at them. I know I get emotional looking at data. But you'll see what I'm talking about. So let's take a couple more questions, and I'd love to sort of get through a little bit more of this. We've touched on a lot of this, so I'll be able to keep moving smoothly, but I do want to make sure that I get everybody. I think that's your 1, 2, 3 questions. Did you have another question or comment?
I was just curious about the Suboxone, and is there like a chemical reaction that it provides that you can't have the opiate overdose, or is it just because your need for the opiate is being supplied?
So,
And as a drug.
how do I want to explain this? I'm going to explain it for real. You have opiate receptors in your brain. Methadone goes in, turns those opiate receptors on full bore. The more you take, the more effect you get. The higher you can get, you can die. Suboxone turns them on partway. You can't get as high, and you cannot overdose on it by itself. We're going to hear more about naloxone as an antidote. It also binds those receptors and just blocks it. Doesn't turn them on at all. So you have an antagonist, it blocks it. You have a partial agonist, it binds partway, and you have a full agonist, methadone. So those are 3 different compounds. And I do have a one-page briefing sheet. So there are some differences in those medications.
So you don't have that basic craving.
So the idea with all of these, and this is the challenge, is methadone has more of a high to it. And so you need to figure out how you're dosing somebody. Are you dosing them so they feel, so here's 2 different issues. You can dose somebody so they don't go into withdrawal, but they may not be feeling a lot of effect. And remember, they might have been using heroin for 10 years and they like feeling an effect. So they may want to be at a higher level. So there's 2 different issues. There's about how much are you sort of feeling good versus are you preventing withdrawal. And that's a fine line to work. I don't know how else to say it.
This is more for Johnny because a lot of the girls I used to work with who were I had all the heroin addicts, and they'd end up in jail, and then they would be ordered through drug court to go on methadone. And Johnny's, in the past, you told me you didn't like methadone; it was more addicting.
See, that's what you remember.
And yeah, I remember. But I have seen, except for one girl, all of them are back using, and they're in their 30s now, and these girls are very highly addicted to heroin and methadone. And some of the reasons that he said, it got hard to get up every day at 7 o'clock in the morning and go down to the methadone, so they would quit and not go that day, and then they would go in the street to buy something because they weren't getting their meds from the clinic, and then they'd get kicked off from the clinic because they'd get dirty urines and stuff. So is that, are we still at that place, especially with the homeless youth, that it's worse for them to get on methadone because they end up back on?
I should probably get real clear here while Caleb's present, because this is like public thing. Like Johnny doesn't like methadone, he won't help anybody get on, then people confront me. Myself, Nick, all my coworkers help people get on methadone very often. I have this personal bias that I give up front, and I give it up, I also talk to my clients a lot about it, that as soon as I say that, we're on the path to what do you want to do. Then the next thing I try to do is help them be successful in the methadone program, which is really what we have a couple people on right now. Do you need a ride? Do you have to go to group? How's it going? What do you think about raising your dose, lowering your dose? We're kind of like that feedback piece for them. How are they being successful in their methadone program? So I feel like methadone's a tool. I also feel like methadone and Suboxone and every other thing that you might throw at somebody is a stepping stone for them to, first of all, stay alive, and secondly, to find some kind of freedom from their addiction. So the drug court thing is another thing. Drug court really pushes methadone hardcore. They try to get 3 of my clients on methadone that never have taken an opiate drug in their life. They, again, another conspiracy statement, the drug court professionals. So that's an issue with I actually had to go down to the treatment center and explain to them that this person's never taken an opiate, they really don't want to get on methadone because they don't really want to use a drug that they've never used before. So there's a lot of information about that. That being said, what's the success of, and some of these girls that have come through New Horizons and other places, some of them are dead, some of them are alive, some of them are doing well, some of them are using. We don't have the answer, the perfect answer, but I know that going on Suboxone and methadone and treatment and any other option is a better option than sticking needles in your arm and sticking the goo, as Caleb likes to talk about, the black tar heroin in your arm.
So let's take one more question, and then I think we've touched on so much of this. I'm going to show you a couple of slides just to show them to you, may give you a visual reinforcement of this, and then we'll take a break in about 10 minutes. But I'm sure you had a short, easy question.
Yes.
No, I don't want one of those.
You mentioned buprenorphine a few times. Is that used kind of by itself like methadone, or is it always in the form of Suboxone?
Okay, so the next part of brain chemistry is that buprenorphine is the opioid. It's what binds to the opioid receptors. Buprenorphine is the generic name for the medication. A brand name, one of the brand names is Suboxone. And Suboxone actually combines it. Remember I talked about methadone, buprenorphine, and naloxone. This is going to get really weird. If you take buprenorphine and you stick some naloxone in it, you have Suboxone. Why would you do that? So Suboxone you take sublingually as a film. You let it dissolve under your tongue. There's other forms, but you stick it under your tongue to dissolve. The reason the naloxone's in there is that if you try to prepare it to inject it, then the naloxone's effective. It's an abuse deterrent. So that's the whole issue. So buprenorphine is the opioid. It's what's having the effect. It's the treatment medication. The brand name Suboxone is essentially just sticking naloxone in it to make it harder to abuse. That's it. Okay. All right. So I'm going to keep going. Well, I won't. Okay. So let me just let you know, 6 million syringes exchanged in King County last year. That's what I'm going to say. And about 15 million statewide. And I'm not going to go into that. So, this is hard to do in 10 minutes.
Sorry.
Well, okay. This is probably the most, important.
Caleb, do you care about this?
Yeah, I care about this.
All right, go for it.
Okay. So, So, Washington State has a Good Samaritan law. Did you know that? A Good Samaritan overdose law?
Raise your hands. Raise your hands.
Okay, so you should all know it, because if I have an overdose on heroin and you're with me, I want you to call 911, and I want you to know that neither one of us is going to get prosecuted for drug possession. That's the bottom line. It applies to any controlled substance. It could be a prescription, it could be illegal, it could be alcohol. So we have a Good Samaritan law. You should know that. We also have naloxone, this antidote that now can be prescribed to anybody at risk for having or witnessing an overdose. So I actually went into a pharmacy and said I'd like some naloxone. I'm at risk for witnessing an overdose. They gave me some education. I took some cash out of my pocket because I'm not on Medicaid. I wasn't billing my insurance for this. And I walked out with naloxone as this antidote. So that's what Washington State's 2010 law does. I hope you're interested in this. The website stopoverdose.org will tell you everything you ever wanted to know. Okay, so I'm just going to tell you this piece as well. 2015 law updated this to just make it easier to get naloxone out there. What it basically did is it allowed prescribing, instead of just to an individual, to an entity. So the Snohomish County Sheriff's Office now carries naloxone, and the doctor had to write one prescription to the police department, not to 200 officers. So that's just a technicality, essentially. And similarly, what we're working on here that could be more relevant where we are right now, this is really important, is a standing order. And this came out of Clark County, out of Vancouver, Washington. Dr. Melnick there, he set up a standing order so that his volunteers and staff at Needle Exchange could just hand out naloxone on his behalf. They didn't have to see a pharmacist. They didn't have to see a doctor. So that's the type of thing that could get put into a place such as this, which would be if you know somebody's at risk for overdose and you have a standing order with a physician, you could hand them naloxone. And that's new.
So New Horizons counts as an entity, so does Youth Ministries Group. We have a few doses of naloxone, and all New Horizons staff has been trained to use it. So if you feel like a young person needs it, then just go to any staff and we can administer naloxone here at New Horizons and you drop it. Youth Ministries and groups also have the same, have too. Yeah.
Right, so the basic thing there is to make sure that staff have it on site so that they can utilize the naloxone. But also, you potentially could be handing it out to youth. You also have it for free at the Robert Cluess Center a few blocks away at the public health clinic, so they can also go there and get it. I will say that when in doubt, if you can hand that user naloxone, do. Because that additional step, just like in everything else, is hard and really ends up being a barrier for folks. Okay. So naloxone is an opiate antidote. It does one thing, it reverses an overdose. You can't get high on it. I am not on opiates. If Johnny gave me some naloxone, nothing would happen. It's very safe. It's been around for more than 30 years. What's most important to know is that it takes about 2 to 3 minutes to have an effect, and it only lasts 30 to 90 minutes. So I like to say naloxone is the short-term rescue medicine. And if you're really concerned about opiate addiction for somebody whose use is out of control and are interested, medications like buprenorphine or Suboxone are the longer-term overdose prevention.
They're showing that they have it right.
Oh, they got it right there? There you go.
To you, Caleb, that they're
Sweet.
Ready to go.
Bam, bam. And that kit right there is this intranasal device. You just squirt up somebody's nose. That's what we gave out in my study. So there's an intranasal kit. which is, I'm going to call it $100, it depends. Medicaid does pay for it, so you should know that Medicaid does pay for this kit. This is also an intramuscular one. You can't really see it. It's a needle and vial, good old-fashioned injecting it. And this is a very fancy little, it's about the size of a Tic Tac box, and it talks to you and is an auto-injector. It's actually modeled off of an EpiPen. And there's actually going to be in the next couple weeks or months a couple new intranasal devices that are a little easier to use. So I'm not going to bore you with this.
Cheaper?
Of course they're not cheaper, Johnny. No, I just got some money to buy naloxone from the state to give out to rural needle exchanges. And let me just say that this kit that actually is not $30 anymore. It's actually $60. And that in 1996 it was $1.50. Right, your congressman. Okay. Yeah.
After you administer that,
Say again?
after you administer the naloxone, then do you still call 911 and get that person to?
So you're going to go on stopoverdose.org and you're going to take the 10-minute training. And the answer is yes. That is what you're going to do. So basically, I'm not doing an overdose training right now. I don't have time to do an overdose training, although we could talk about it more later. But basically, you need to know how to recognize an overdose and you need to know how to respond to it. So you always want to call 911. You always want to call 911. It is a medical emergency for a person to stop breathing and turn blue. Even if you wake them back up, it's still a medical emergency to happen. You don't know what else is going on. So that's really important. So the idea is it's all about oxygen, the person not having enough oxygen. So you want to get them breathing again, and naloxone can do that, or you can do rescue breathing for them while you wait for 911 ALS medical one to get there. So, but yeah, so please go on to stopoverdose.org webpage if you're interested in this and just do that quick online training. What else do you need to know? I don't know what else. That's the quickie on naloxone. I don't think I'm going to bore you with that. There's a lot more naloxone now than there was 5 years ago when there was none getting distributed out there. I think what's important just to know is it's at needle exchanges. It's actually given out at the Kent jail. It's the second jail in the country doing this. Coming out of jail or detox or anytime you stopped using opiates and you're released back into the community, the biggest risk for overdose. So I'm super excited and proud that they're doing that down at the jail. You got some medical providers just prescribing. Docs could have been prescribing naloxone for the last 30 years. They just didn't. I won't comment on it. They just didn't do it. And we've got the South County homeless van, mobile van. These are all pharmacies that have collaborative practice agreements. Super quick. In Washington State, a pharmacy can get set up just as I described, so that instead of me having to go to my doctor to get a prescription and then go show it at the pharmacy, a bunch of pharmacies, and all of them are on the website right now. You just go to the pharmacy and say, I'd like some naloxone, and they give you some education, and you get the naloxone. So that's pretty cool. It's not quite over the counter, it's behind the counter, but it's pretty good. And actually the Wazoo, they trained all their RAs, and they have naloxone on campus. And some police are carrying it. Lummi Tribal Police are carrying it. Worth you knowing that in a few months, some of the bike patrol officers in Seattle will be carrying naloxone as well if they see overdoses. I'm not going to go into naloxone stuff anymore. I guess what I will say is, you got to recognize, call 911, do rescue breathing. You should know about the Good Samaritan law, so people will call 911. You need to realize that in talking about naloxone, it's actually a great opportunity to talk about opiate addiction. So when I go train police chiefs or ER docs, they're like, yeah, it's great, we saved their life, then what? I'm like, exactly! It's about opiate addiction. Let's talk about opiate addiction. So it's great to save that life, but then what? Then you got to figure out the next thing. And clearly, cautious opioid prescribing in the first place is super important. We're doing a lot of work on that. Quality drug treatment is the long-term solution. We need sort of easy access, right? You disagree with anything, Johnny?
No, I love all this. I love it.
Oh, dang, I said methadone. Okay, just kidding. I'm totally messing with it. So, but I do, this is just a one-page thing on our website. All you have to remember is ADAI, or my name, it's pretty easy. It's just a one-page overview of these medications and their role in treatment, if you're interested.